fourth largest in the world. Apollo is the largest hospital network in Asia. That being a world-class healthcare provider is not just about medical expertise. It's about touching lives.
Yeah, Dr. Khanna.
Yes.
You are live.
Okay.
Yeah, I'm Dr. Bedi here.
Yeah. Good morning, Dr. Bedi. How are you? Good. Good morning to all of you. Yeah. What we are doing here is, after you have seen that aneurysm case, now this is a patient of a Takayasu arthritis. He is a young male who is 28 years old, and he's got occlusion of the right subclavian artery, the right common carotid artery, and tight stenosis of the left common carotid artery. He presented with recurrent dizziness, episodes of dizziness and blackouts, and also very significant claudication in the right upper limb. So at that stage in an emergency, when he came to us earlier, what we did was we tackled the subclavian artery, and we also tackled the right common carotid artery. We opened the total occlusions, which I'm going to show you, put him on a heavy immunosuppression, and now we have called him to open this left common carotid artery, which you see on the screen. So I'm going to run you through the angiograms and the procedure which we did earlier. Can I have the first slide, please? The first picture of the angiogram. Okay, so this is the coronary angiogram, which is, can you see it on the screen? Okay, so the coronary angiogram is normal. Okay. Just hold it here. So this is the angiogram of the right innominate artery. You don't see anything beyond the first part of the subclavian artery, and you don't see anything in the common carotid artery after the ostium. Next, please. So what we do, we manage the subclavian artery first. We took an Aquatrack wire, and on the Aquatrack wire, we tried to get it with a 3 French Terumo catheter, and we did not know whether we went subintimally or we went through the lumen. But to be sure, we passed in the catheter. Next, please. Once we had the wire, we got the catheter right up to...
We couldn't see the arch angiogram. Yeah, I was wondering.
Okay, yeah. I'll just go back and show you.
We couldn't see the arch angiogram initially, the autogram that you did.
Yes, we have. I'll just show you. Maybe after this also I've got it recorded. I'll show it to you. So this is, so once we were sure that we are in the true lumen, we wired the vessel again. Next, please. We withdrew this catheter. We changed the wire. And now we have a track. We do not know it's subintimal or intimal, whatever, intraluminal. But we had a track, and we wanted to now dilate this subclavian occlusion. Next, please. Now we got, this is a DSA picture of the same. Next. Next, please. Next. Can you go next? Okay. So this is a balloon from Invatec. This is a 120 millimeter balloon into 4 millimeter. This is an ampheron balloon, and you see how tight is the stenosis. We had to really go up to pressures up to 12 to 14 atmosphere. And after we dilated it, if you see this picture carefully, just run it again. No, go back. Go back. Go back. Back. Go back. Oh, just play the picture, please. So what we did, once we dilated it, what we saw, because it opened with a lot of pressure, there was pain. there was a sort of a perforation, and this perforation was sealed. If you see this, there is a leak. Go back, please. There is a leak, and there is a AV fistula which actually drains into the subclavian vein. So, if you see that on the lower side, there is a vein which fills up. I don't know whether you can appreciate. Next, please. Please run it. So we took a balloon again and dilated it and tried to tack it for another 3 to 4 minutes. But the AV fistula did not close, so we had to put a covered stent there. Next, please.
Why will the AV fistula be made here with the balloon?
I do not know. It was not a balloon. I think there was a perforation because of arthritis. These are panarthritis, and they involve the artery as well as vein. If you see the new literature, I do not know. I think it was a small perforation, but it was leaking into the subclavian vein or into some vein. So then we thought we'll put in an atrium stent. This is a 6 millimeter atrium stent. Next,
so,
please. But while we were trying to
kind of AV fistulas very often. We see this very often in the femoral level that we have AV fistulas after PTA. I'm not completely sure if there really is a need. That's why for putting in a covered stent. But on the other hand, maybe for the Takayasu treatment, you will end up in better results with covered stent. May you have not these frequent reinterventions. Do you have an idea for this, how it works?
I do not know, because I wasn't sure how fistula is going to behave. It did not tack up with the balloon, so we thought let's put a covered stent. What it's going to do with the high ESR, maybe it will prevent the neointimal proliferation, and it will seal the fistula also. But what was more interesting is when we tried to put this covered stent, next please, we were using an arrow sheath at this point of time. The covered stent, the atrium stent could not be crossed across into the sheath. Just hold on. And we really had a hard time getting this atrium stent out, and we had to pull the whole, push the whole assembly beyond the occlusion into the sort of axillary artery, and then pull it back and pull back the sheath. And later on, when we saw the IFUs of the atrium stent, we see that the arrow sheath is one of the contraindications. This stent should not be used in an arrow sheath because somehow it gets caught into the internal braiding of the arrow sheath. Now, this is the final result which we got on this subclavian on the right side. Next, now go to next one. Then we attempted the common carotid on the right side. This is the final angiogram. Next. Now, this is the stump of the common carotid on the right side. So we went, this time we went with the shuttle sheath from Cook's. Next. And this is an angiogram, the DSA picture. We had a road map, and on the road map, we crossed the lesion with the 014 wire. Next, please.
Just a question. A common carotid occlusion is actually a contraindication for a carotid stent for atherosclerosis. So why do we go ahead and do it in this kind of a patient?
Because this patient is very symptomatic. This patient had recurrent attacks of dizziness. His 3 arch vessels were occluded, and this patient we had to we had to intervene to revascularize his cerebral circulation. Now, we had no other choice.
But you had a left carotid stenosis which you were going to open anyway.
The left carotid stenosis, if you see on an angiogram which I'm going to do today, is 90%. And he had a severe claudication on the right side.
So you're using a protection device, embolic protection like a filter system. If you are in with a 14-inch wire, maybe it would be a good idea or not?
No, because in Takayasu arthritis, these are not atherosclerotic lesions. The risk of embolism is actually very low. And we never actually use distal or proximal protection devices in this sort of situation. Now, we have a very good experienced panel. I mean, I would like to know their opinion if they want to use a protection device in these sort of patients.
Dr. Khanna, we've been doing a lot of carotid occlusions, common carotid occlusions in Takayasu, maybe more than 100 now. And what we find is in these, when you do the arch angiogram, you will see reformation of the carotid bifurcation through collaterals.
Correct.
And you will see flow from the external to the internal carotid and up into the brain.
Correct.
So you know that the distal circulation is patent and flowing. And through the occlusion, very often when you wedge a catheter and take a shot, you'll see tiny channels through this occlusion that lead to the distal vessel. And we then just get through with a hydrophilic wire balloon and most often stent. And we've had very, very low incidence of thromboembolism in this. Sometimes we have very rarely we've had 1 or 2 TIAs, but apart from that, for a primary recanalization, we've never had a problem.
Yeah, that is my experience also. I mean, the success rate with carotid occlusions is much higher than that of subclavian occlusions. Even the subclavians actually do quite well. Okay, can I go to the next one, please? Next film, next loop. Okay, so on a roadmap, go minus, I think you jumped. So what we did, we we dilated the lesion with a 5 millimeter into 120 millimeter balloon from Invatec, which is an amphiron balloon. Now this balloon is very good. It is very low profile. It's hydrophilic. It's used more for below knee, but even for carotid and subclavian occlusion, it works very well. I did not purposely wanted to put a stent in this vessel because his acute phase reactants were high. He was in active disease, and we just wanted to balloon it and see how it goes. Now it's been over 3 weeks now. I mean, his ESR is now down to normal. His carotids are fine. There's no carotid tenderness. And go next. Next. This was the result which we had achieved, and we left it at this stage. Go next. And if you see this angiogram carefully, it is what I think somebody in the panel was commenting. Can you show that angiogram? There is a flow into the external carotid, and it looks like a negative flow. That's why it's not filling very well. The internal carotid fills very well. Normally, the disease does not involve the internal carotid. It is sort of localized up to the common carotid or the bifurcation. And there is a good flow from the external into the internal. One for well. So
and a
this
good thing to note is that ICA diameter is bigger than the CCA.
Right, because I haven't dilated the CCA to the full level. I mean, I think it's better to just leave it at a suboptimal stage. We do not want a cosmetic result. Otherwise, we'll end up putting in a stent.
Can we see the innominate and the right subclavian, how that is?
Yes.
Do the patient have pain during the PTA?
Yes. The patient had pain only when we were dilating that subclavian and when there was a small rupture. Apart from that, there was no pain. Now, if we can come on to the monitor, I'll show you what we are doing today. Can you see the screen now? Now? Can you focus on this screen now? Okay, main camera. So this is, we have gone today with the arrow sheath, and this is the angiogram which we are doing today. Now this is the left common carotid artery. You see there's a stump and there's a long stenosis. And then there is a filling through collaterals of the left common carotid bulb, which you can see, and probably from the external into the internal. Now we are going to, what we have done is we have taken a 7 French arrow sheath. We have got a 4 French RCA diagnostic catheter to engage this common carotid ostium. Now we are going to wire this under roadmap and then dilate it, and if required, stent this artery. Roadmap.
Dr. Khanna, if at any stage you could just show us an arch angiogram at the baseline or at the start today,
I think probably I'll show you at the end of the case because they haven't, they have got it on the different machine, they have copied it on the laptop, and that's where we were showing you the whole procedure from. Now, after this, I'm going to show it to you again. Let's go to road map pe jao. Go to the road map. Road map. Okay? Fine. So we do most of our procedures under road map because it 300. Because it saves the contrast and it gives us a very good idea of what we are doing. Now we have taken a 300 centimeter 014 extra support guide wire.
So we in Europe see not so much Takayasu. That's why I have not so much experience like you here like this. But if you had to put in stents in this segment, what kind of stents would you put in? More nitinol stents because of the movement, or would you put in a balloon expandable stent more in the area of the aortic arch, or would you like to have a combination between two stents?
Nowadays we just put a single long self-expanding nitinol stent, and we currently use the Medtronic Complete SE, and we make sure that we cover the aorta-ostial segment, and it actually should project a little bit into the aorta. And at the upper end, it should end beyond the lesion. So we tend to underdilate when we do the initial procedure. We don't go beyond 5 millimeters. But that 5 we may achieve by using a non-compliant balloon like the Conquest.
Yeah, I mean...
The other thing we find is when we follow them up after a year, the stent expands to its full size on its own, you know. And then sometimes the lumen is even bigger than what you left it.
Correct, you know. I would definitely think that we should use a nitinol stent, and as I would agree with Dr. Joseph, you know, we have seen so many times that the stent would expand. If you see the angiogram after a year or so, slowly and slowly the stent expands to its size, which is bigger than what we had put with. Gone up, no?
I think another thing is if you have seen these arteries, which we do sometimes surgically, you really wonder if any balloon expandable stent it's really going to cause a rupture of the artery. That is what is going to happen with a balloon expandable stent, because the arteries are absolutely stiff. So I think a nitinol is probably the best option.
And now we have long stents from, we have a Complete SE, we have a lot of stents from Abbott, Cordis, which are good stents, which are both open cell design, closed cell design, and also which are hybrid stents, and all of these work very well. I mean, but okay. So now we have got the wire across.
The subclavian cases.
Balloon.
If you look to the subclavian cases, is there maybe a
110, 120.
good thing if we do atherectomy?
4 millimeters.
Because you say we have very often restenosis. Maybe atherectomy and a drug-coated device in combination, would this help?
Generally, there is always a very thick wall. It's not really like a plaque. And the second thing is the lumen is always contains a lot of thrombus out there. That is the reason for the occlusion. And when you look at it, there is no plane as such which you normally get with a normal artery. So you just won't know where to stop cutting. So that's the major problem, and the chances of having a complication are very high.
So now we are going to take a amphiron balloon.
That's a road map. That's a road map, so there will be some movement. There will be parallax out there.
Talking about cutting devices, we were very enthusiastic about cutting balloons in Takayasu in general when in the mid of last decade, 2003 to 6. And then we found that we are having a lot of ruptures because this disease, somehow the cutting balloons, they cut, but they cut sometimes too much. And once we stopped using cutting balloons, our rupture rate has really dropped. Now we rely more on high-pressure balloons and stage dilatations.
Okay, connected.
Maybe a silver PDX stent would help. Maybe the silver PDX stent would help in this case. Maybe.
नीचे दिखा ओह वायर निकल गया Get me the...
Dr. Khanna, can you tell us what you are doing now?
Yeah, we had a wire across. Yeah, we got out of the ostium. Can I have that RCA catheter again? We had hooked the common carotid, we wired it, but now while we are negotiating the balloon inside, the guiding catheter came out. Give me a 300 centimeter wire. So we are going again. We are taking a 4 French RCA catheter inside this sheath and trying to rehook the ostium.
What we do now is we work on a 035 platform and a long sheath. So what we do is we first cannulate with a diagnostic catheter, get a hydrophilic 035 wire up into the internal, then slide the catheter in all the way to the internal carotid, and then bring an Amplat super stiff wire and park it with its soft end in the internal carotid. Then work with a long sheath, and that gives us tremendous stability, and then we can, we work basically 035 balloon and stent platform.
Right. I mean, I wanted to do that also, but our lab, if you see you're on a roadmap, we can get on with this wire. But our lab has more of 014 and 018 system. Just hold this. Hold this first. So we are now taking out the catheter, and we have wired it. Now we are going to take a 5 millimeter balloon into 100 millimeter, and then trying to dilate this. Okay, now. First. So this is a Pacific balloon from Invatec. First.
Is this an 18-inch wire or 14 now?
This is a 14
Maybe
wire.
To
It is
the Pacific you can exchange for an...
Yeah, a Pacific takes a 18 wire, but we have got a 14 wire because whatever we want to do, we can do. It's a All-Star, which is an extra support guide wire. Hold. I think we are going to hold the wire. I mean, I would try not to stent this lesion. I want to know the opinion of the panel. If I can get a good result without stenting, I would still prefer that. Yeah?
Yeah, so we'd need to do the balloon angioplasty and then do an angiogram and then make the decision. Very often,
go off.
especially in the younger patients, we tend to see a smooth outline if you have just done a very limited dilatation, and you can get away without stenting if that's the thing. But you'll have to see the angiogram first.
Go up.
Samir, you have anything different, or you do the same?
No, I agree completely. I think key is to get a good result.
Once
not
again,
to do stenting or not to avoid stenting. That is secondary.
Girish, your take?
I would think so. I mean, try and avoid it such a long segment. We would think of just doing a balloon and see how it goes.
I think Gurpreet and Rahul will also agree to that.
Yeah, I would actually accept 40 to 50% residual stenosis with the balloon. Yeah.
Now
I think in principle, everybody agrees on the panel.
1 second.
That we should just do a plasty and leave it at that and then see.
Now you see how tight is this lesion. We are at 8 atmosphere. The patient is having pain, and the lesion doesn't open up. So what we do is we stay for some time, or we do repeated. We go like from 2 to 8 atmosphere, like we were doing it in coronary, so that we can actually open this lesion well. Now it's open, and now we are going to give a prolonged dilatation here.
You have? What pressure is there?
Now we are at 10 atmospheric pressure.
What's the pressure you...
10 atmospheric pressure. This is a Pacific balloon. The patient has some pain. Hemodynamically, he is okay, but we cannot do a pulse check. Now we want to give 2 to 3 minutes. The heart rate is 91. 91, and the patient is now tolerating this balloon dilatation quite well. He does not require a pacemaker support. The pain, abhi koi dard hai? The pain is not there right now. The maximum of the pain occurs when you stretch the artery and the lesion is not dilated. So we are going to give it for another, say, 1 or 2 minutes because we would be running short of time. And then...
Dr. Khanna, we just have about 2 minutes of satellite time.
Fine. So what I'm going to do is, I'm going to take a final shot and show you the result.
What's the size of this balloon? And
this is a 5 into 120 millimeter balloon. Just hold this.
And is it a non-compliant balloon or semi-compliant?
This is a semi-compliant balloon. The rated burst pressure of this balloon would be 14 atmosphere.
Normally 14. Yeah.
But you can go up much higher. So in the SFA sometimes we go more than 20.
But here you can't.
Yeah, maybe here not.
Okay. Can I have a DSA? Mr. Bhutia, just hold your breath, okay?
You could see very nice how he pushes in the sheath a little bit by pulling out the balloon, so it helps to bring the
So this
sheath
is the
again
result
in
which
stable
we have got, and I think it looks pretty good. I may give another
That looks
balloon.
pretty good.
Yeah, I may give another balloon dilatation with the same balloon, or maybe take a 6 millimeter balloon and finish this procedure. Because I really don't want a lot of dissections here, and the main purpose is to improve.
I just take the opinion of the panel.
I would actually reintroduce the balloon and do a prolonged infusion at 4 atmospheres just to try
Dr.
and...
Khanna, I'll just take the opinion of the panel as to what do they feel, whether they would like to dilate it further with a 5 or 6. Dr. Matthias, your
So, because of the pain, I would not go with a bigger diameter or only really carefully, but I think it's a good idea to go in again with the balloon and stay there for maybe again 5 minutes.
And low pressure.
And low pressure. Or 6 millimeter and low pressure, because normally the common carotid is around 8 millimeter. But here, if you have a high risk for rupture and pain, maybe just put in the 5 millimeter balloon for a longer time. It's a good idea.
Okay, so I also think the
we've
same.
learned the hard way that first time round we don't go beyond 5. If we go 6 only the second time or maybe 6 months or a year later. If the 5 gives a satisfactory result, I'd leave it at that. I wouldn't go for the 6 at the first round.
Right. So I have taken your
anything different?
No.
your opinion and put a 5 millimeter balloon back into the position. We are at 4 atmospheric pressure, and we want to give a 3 to 4 minute prolonged balloon dilatation so that it can seal up the dissections and open the vessel a little better.
We may be losing you any minute, Dr. Khanna, but anyway, thanks very much for a wonderful presentation again and a wonderful demonstration of angioplasty of a CTO of the carotid. Thanks very much. Really enjoyed watching this.
Thank you very much. Thank you for being with you.